So, sir, it's 3, 2, 1. We are live now, sir. Over to you.
Good evening, everyone. We are here to discuss upon the topic of very important topic of renal stones, metabolic evaluation, and a brief abbreviation of information on the medical management of it. I am Dr. Sandeep Prasad. I am consultant urologist in Fortis Hospitals, Kolkata, and I will be presenting this topic for you. So the question first arises: the why a metabolic evaluation has to be done for any case. It is to be done to prevent recurrent stone formation in high-risk stone producers. And now, who are high-risk stone formation? I will discuss it later. It is to prevent further growth of any existing stones and to prevent any extrarenal complications if there are associated systemic disorders, which we can get by metabolic evaluation. So, what is the prerequisites for this test? So, whom should be done, or what should be done? The criteria for implementation of this test. It should be simple to perform. It should be economically viable, and it should provide information that can be applied toward a selective rational therapy of stone disease. These three are the main criteria for the test for metabolic evaluation. Whom should we select? First-time stone formers are a contradiction to whom whether to be put up for metabolic evaluation or not, because they have a 50% risk of recurrence within the subsequent 10 years. But one stone clinic effect has also been shown where single stone formers who are placed on a high fluid conservative therapy, along with evidence of any excessive dietary products which cause the stones, have shown to be lower incidence of recurrent stone diseases. So whether we should take them or we should not put them is, as told by AUA, American Urology Association, is to be a shared decision made by the physician and the patient. First-time stone formers should be informed, if they're not high-risk stone formers, that it's a shared decision that you and I have to take together, which we do while training all the requirements, all the pros and cons of the evaluation. So formation of first stone may be the harbinger of a more severe underlying systemic disorder also. There's a renal tubular acidosis, hyperparathyroidism, hypercalcemias of hyperparathyroidism, primary parathyroid tumors, or any renal or other malignancies can also be there. In such patients, metabolic evaluation is justified solely to make the correct diagnosis in order to prevent external complication. So after stone passage, every patient should be assigned to a low or high risk stone group for stone formation, and we can go on to metabolically evaluate them as per need of the risk. So for correct, two items are mandatory. If the stone has passed spontaneously or you have taken out the stone by any procedure, you must do a stone analysis by a spectroscopy, infrared or X-ray diffraction. The metabolic chemical analysis of yesteryears are no longer taken as the procedure of choice. So basic analysis is same in all patients who undergo a high risk for stone recurrence and should undergo stone specific metabolic evaluation. It includes dipstick of your spot urine sample for red cells, white cells, nitrite, urine pH, and microscopy and culture. And blood sample has to be taken for creatinine, uric acid, ionized calcium, sodium, potassium, blood cell count, and C-reactive protein. This has to be done for all the cases. Now, this is the chart given by European Association of Urology. They are telling if you get a stone out and a stone analysis is known, then do a basic evaluation as I told in previous slide for all the cases. If he comes out to be a high-risk stone former, then do a specific metabolic evaluation and stone specific recurrence prevention has to be done. So we will discuss about all these things, that how to do a specific metabolic evaluation and how to also specifically prevent recurrence of the disease. And if it comes out to be a low risk stone former, then go for a general preventive measures. So this is European Association of Urology. They told like this. So when to be done? For the initial specific metabolic workup, the patient should stay on a self-determined diet under normal conditions and stone free for at least 20 days. So after procedure, you can take the patient for doing the procedure and metabolic evaluation for 20 days. Follow-up studies are necessary in patients taking medication for recurrence prevention. And the first follow-up 24-hour urine measurement is suggested at 2 to 3 months. So only one metabolic evaluation will not do. You have to follow up. And after 2 to 3 months, the first follow-up should be there after starting pharmacological prevention drugs. Once urinary parameters have been normalized, It is sufficient to perform 24 urinary evaluation every 12 months. So 2 to 3 months, after 20 days you do, after 2 to 3 months you follow up the case, and after every 12 months yearly, you go on having perform one urinary evaluation for any high risk stone forms. Who to be done? These are all all the criteria listed here are all high risk stone formers. These are recurrent stone formers, strong family history of stones, intestinal diseases, pathological skeletal fractures, osteoporosis, history of urinary tract infection with calculi, personal history of gout, infirm health, solitary kidney, anatomic abnormalities, renal insufficiency, and stones composed of cysteine, uric acid, or struvite. Abbreviated evaluation. This is nowadays done mostly for all the cases which we do. This is if we take a history of any underlying condition, when the medications is taking, any dietary excess of anything is sorted out by history. A multi-channel blood screen, as I have told before, all these are done, and urine analysis pertaining to the pH and urine culture and qualitative cysteine are taken. Radiography is done to rule out radio-opaque and radiolution stones. It is basically an X-ray only to be done in this stage. And intravenous pyelogram is to be done when cases of radiolution stones, or if we are suspecting any anatomic abnormalities in the case. And stone analysis finally by X-ray diffraction or infrared spectroscopy or nowadays micro-CT. On stone analysis, the crystals these are all electron microscopic views of crystals with apatite, amorphous with cysteine hexagonal brushite is needle shaped and diaeded hourglass. This can be found out on stone analysis. Now we come to extensive diagnostic evaluation. It should be performed in patients with recurrent stone formation. That is the patients who are at high risk of stone formation. This should be done to identify underlying physiological derangements. So patient has to continue any medication that discontinue any medication that interferes with metabolism of calcium, uric acid, or oxalate, and any current medication for stone treatment like thiazides or magnesium or allopurinol, whatever he has to discontinue that drug. After that, it involves two. Now this slide I have written not followed because these 3 24-hour urine samples are not taken nowadays. Now recommendations are only for 2 samples, one random and one on determined diet. So earlier it was done that 3 24 hours were taken, and the first 2 24 hours specimens were taken on random diet, which were reflective of the dietary intake, and the first one was there on calcium, sodium, and oxalate restricted diet. So they could find out whether any absorptive hypercalciuria or hypocalciuria is there or not. That is why. But nowadays we perform only 2 24-hour urine samples. So outline is of extensive metabolic evaluation of 2 visits. First visit we take a complete blood count, complete metabolic panel, calcium, creatinine, sodium, pH, volume, oxalate, citrate, and cysteine qualitative evaluation is done. On second visit, we only do a complete metabolic panel, and PTH is done in second visit where the restricted diet is there. Calcium is taken, creatine and rest all are again repeated same way. And fast and load calcium test are also been done, which I will discuss later. Here 24-hour urine on restricted diet and normal is being used to see whether the absorptive hypercalciuria is present or not. It discriminates between various forms of hypercalciuria and it is no longer performed, but it is of historical interest, so I put it here. Essentially, if plan is to place a patient with absorptive hypercalciuria on a calcium binding resin, if you want to put it, then we can do in this. The 400 milligram of calcium is a 24-hour urine on restricted diet has been taken, and then after the loading dose is given, and then urinary calcium is being tested. Normal fasting urinary calcium should be less than 0.1 milligram per DL, while normal post-load urinary calcium should be less than 0.2 milligram calcium per creatinine. Simplified metabolic evaluation. All patients should be going a basic metabolic screening, and high dose patients should be done extensive metabolic evaluation on 2 24 urine samples. Cornerstone of this is to development of a urine preservation method that allows collection of urine without refrigeration. So refrigeration was a essential hindrance in the pathway of these processes. So now we have very good preservatives available in the containers which you are given, which can in which we don't have to refrigerate. You just have to take the sample throughout 24 hours and give it to your lab. The next after the next morning urinary you have passed, you can give it to the lab and they will process it out. So the earlier days, ice has to be carried out, refrigeration has to be done. That was to be done, but nowadays it's very easy and very convenient for the patients. So urine constant most commonly acid are calcium, oxide, citrate, volume, sodium, pH, uric acid, and sulfate. Sulfate is done. All are understood that is done, but sulfate is done to check for the dietary protein. Protein gives out sulfate, which is acid, and protein content is being estimated. So stone analysis to determine metabolic abnormalities. Most stones are mixture of more than one component and relative ratios or predominance of any particular molecule has predictive value. So calcium apatite and mixed calcium oxalate, calcium apatite stones are being found in RTA, renal tubular acidosis, and primary hyperparathyroidism. Uric acid stones are found in gouty diathesis, brucite in also same in RTS. Infectious stones, struite stones in infection, and cystinuria stones in cystinuria. Imaging and determining DECT is a dual energy CT. Nowadays are being used to distinguish between uric acid and calcium phosphate and calcium oxalate calculi. They give a Hounsfield, they're different Hounsfield for all the stones. Uric acid stones are very soft stones. So they give a Hounsfield of 200 to 450. The most strong stones are calcium oxalate monohydrate stones. They give up to Hounsfield of 2800 to 3000. And calcium phosphate are brittle stones which can be easily broken but not soft. So these are 1200 to 1600 Hounsfields they give. Then this is helped in differentiating between the stone composition. So diagnostic criteria, these are all the things which can cause stones formation, which we can get by metabolic evaluation, we can diagnose. So absorptive hypercalciuria is of two types, type 1 and type 2. One is dependent on your food. If you stop the food, it will be improving. Other is not dependent on food. So on absorptive type 1, calcium loading dose is more. Calcium restricted dose is also when calcium urinary is more. In absorptive calciuria type 2, fasting calcium is more, rest all are normal. Renal hypercalciuria is renal phosphate leak, and everything leaks. So the PTH is more, so calcium is more in urine. After loading also calcium is more. After restriction of calcium also calcium is in more. So you are not able to control by anything. So if all the parameters are low, high, so it is like a renal phosphate leak. Primary hyperparathyroidism, PTH will be more. Unclassified hypercalciuria, calcium fasting loading restricted will be more. Uricosuriya, uric acid will be more. Enteric hypercalciuria, oxalate will be more. In hypocytruria and renal tubular acidosis, the hypocytruria is there, so their citrate will be less. Gouty diathesis, uric acid will be normal or increased like that. So these are the things all can be diagnosed on basis of this extensive metabolic evaluation. Now, what are the general preventive measures which are to be taken for stone formation after we get a stone? What we advise? Three basic advices are there: fluid recommendations, dietary recommendation, and obesity and lifestyle changes. Fluid is, as it's water is the best fluid of all. No other fluid can match the quality of water in flushing out kidney, flushing out stones. So water has to be used everywhere. Water is the most important fluid. It has to be taken 2.5. It has to be taken at least 3 to 3.5 liter, so that a urinary output of 2 to 2.5 liters of urine can be achieved per day. It has effects is by mechanical diuresis and creation of dilute urine, which alters the supersaturation of stone components. Water hardness, although water hardness can also alter urinary parameter, does not play a significant role in recurrence risk. Carbonated beverages. Carbonated water offers increasing protection against recurrent stone formation by increasing urinary citrate levels. So this Coca-Cola, Pepsis, and all black and all drinks, they all are flavored with phosphoric acid and they increase stone risk. Whereas those with citric acid may decrease the risk. So caffeine intake may increase the risk of stone recurrence in calcium stone formers by increasing excretion of calcium. Citrus juices, lemon and orange juice may be useful agent to prevent stone formation. In protein restriction, incidence of renal stones is higher with increased animal protein intake. On the contrary, the vegetable protein has got a lower rate of stone formation as compared to animal protein. So, if you want to have protein, go for vegetable protein if you are a high risk stone former. Protein intake increases as it increases urinary calcium oxalate and uric acid excretion. The probability of stone formation in within normal subjects also increase. So diets high in fruits and vegetables impart a reduced risk of stone formation than in animal protein. Sodium restriction is very important. An important part of dietary prevention of recurrent temporal high sodium intake increases calcium excretion, pH, and decreases citrate. So net effect is crystallization of calcium salts in urine. So animal protein restriction should be done for the sodium restriction, and calcium ingestion should be moderate and reduce sodium diet. If all these are followed, 50% chances of stone formation are decreased. So calcium stone formers who ingest large quantities of daily salt are more likely to suffer from decreased bone mineral density. So that is to be taken. The daily salt has to be moderated. It should not be taken added, like added salt should not be taken. It should be in moderated amount. That should be always taken care of. Dietary calcium restriction. Now, dietary calcium restriction doesn't mean you have to stop all the calcium you are eating. Dietary calcium has to be moderated, not stopped. More word is moderation. So, evidence supports maintenance of a moderate calcium intake in calcareous nephrolithiasis. On the other hand, if you stop calcium, then the all oxalate combines with and then stone formation. Then the oxalate it doesn't get combined or calcium to combine. So it forms other varieties of stones much more. So it has to be taken that moderate calcium intake is taken in all cases. Dietary calcium restriction may subsequently increase oxalate absorption, thereby rising calcium oxalate supersaturation. So calcium supplementation, we mostly in postmenopausal women and persons who are ladies and elderly ladies, elderly men who are taking calcium supplement, they have to be followed. It has to be taken with meals so that oxalate calcium can combine with oxalate. Calcium can combine with citrate and get easily flushed out of the kidney and doesn't form insoluble salts. And second, which type is most better for eating is calcium citrate. It is known as the stone-friendly calcium. So don't go for carbonates. If you have a carbonate, then you have a high risk of stone formers. If you are eating citrate, calcium citrate, you are in safer zone. Oxalate avoidance is the primary thing after dehydration correction. So avoid excessive dietary oxalate in reasonable intensity. Vitamin C in large doses by conversion to oxalate may increase the risk of stone for recurrence. So vitamin C in large doses is prohibited, should not be taken, and limited to 2 grams per day. What are the foods which contain high oxalate? Tea, cocoa, spinach, mustard green, Swiss chard, beets, okra, berries, berries, all berries. And there is no sum like that. It's like no berries you should take, whether it's strawberry or raspberry or blackberry. Nothing is good for kidney. Chocolate, nuts, wheat germs, soy crackers, or paper. These are contain high, so that has to be avoided. Increased BMI. Obesity is good for nothing. Obesity is good for nothing. It increases, it has ill effect on all the parts of all the organs of the body, starting from malignancy to BP, hypertension, and everything. So increased BMI, large waist size, and weight gain correlate with increase of stone episodes, and it is more pronounced for women as compared to men. Metabolic syndrome, 4 components combined together: hypertension, hypertriglyceridemia, glucose intolerance, and central obesity are combined together are known as metabolic syndrome, and this is gives a high propensity for stone formation. And by impaired ammonium excretion, here we can see the ammonium excretion when it is impaired, the H plus is given, low urine pH becomes low, and the uric acid stone formation becomes more prominent in acidic urine. So some people go for weight loss diets, which a low carbohydrate and high protein diet delivers a marked acid load to kidney. So which increases risk for stone formation and bone loss, both. So if you have to go for diets, go for diet rich in fruit and vegetable, which is low in protein, not much high in protein, because this high protein always goes for kidney, not only stone formation, it also goes for parenchymal damage also. Instead, dash is the dietary approach to stop hypertension. Diet is recommended which is rich in fruit and vegetable and is low in protein. Bariatric surgery, if you're going thinking of going for bariatric surgery, it also increases your risk of stone formation. And jejunal bypass before and Roux and gastric now are both increased oxalate nephropathy and nephrolithiasis stone formation. So you have to be aware of that. This is our European Association Urology guidelines on fluid intake and balanced diet and lifestyle advice. The European Association tells that fluid amount should be 2.5 to 3 liter per day to be taken. Circadian drinking should be there. The neutral pH beverages should be taken, and diuresis of 2 to 2.5 liter per day as a aim should be the aim. The specific gravity of the urine should be 1.010 per day. Nutritional advice for balanced diet, they tell you to take a balanced diet which is rich in vegetable and fiber with calcium of 1.2 gram per day and an NaCl of salt of 4 to 5 gram per day. And animal protein content should be 1 gram per kg per day. So 60 gram per kg, 60 gram in a healthy male or 55 gram in a healthy female should be taken per day, not more than that. BMI is to retain a normal BMI level and adequate physical activity should be there. Balancing of excessive fluid loss. So if you, whenever you are doing a excessive physical activity, your fluid loss is there, you try to balance this by drinking water. This is also a chart showing what is to be done in patients, dietary modifications, what the fluid recommendations and lifestyle. I just want to, I specifically posted this chart, I liked it, that I want to tell about this, see how much water we should drink. Here for calcium oxalate stones, they to drink 12 glasses of water per day. For uric acid, 12 glasses, cysteine 12 glasses, and struite 12 glasses. So the primary method of prevention for any stone is to drink around 12 glasses of water per day. This has to be kept in mind. That's why I put this chart. Selective medical management. If you get a stone after a metabolic evaluation, we get a stone of specific type, then what has to be selective medical management? If you get hypercalciuria in metabolic evaluation, so what will be the characteristics of hypercalciuria? There are 3 types of hypercalciuria: absorptive, renal, and resorptive. So in an absorptive hypercalciuria, as you will see, the intestinal calcium absorption is more than normal. In renal, there will be fasting urinary calcium is more. Renal tubules leak sodium and calcium and phosphate. So there will be much more available. In resorptive, there is parathyroid function, primary hyperparathyroidism causes this kind of hypercalciuria. So if hypercalciuria is more than 200 milligram per day of calcium excretion, if it is type 1, there is increased urinary excretion of calcium on calcium load and calcium restricted diet. In type 2, that elevated urine calcium on fasting only, while normal on calcium load and restricted diet. So type 2 can be managed with restricted diet. Has to be high management restriction of diet. Calcium has to be taken while if you have diagnosed with AS type 2, absorptive hypercalciuria type 2. A low intact PTS due to suppression from a constant abundance of available serum calcium is there in absorptive hypercalciuria. So this is also a paradox kind of thing. Treatment of absorptive hypercalciuria is type 1 is thiazides is the drug of choice with potassium citrate to overcome the hypokalemia caused due to thiazides, and dietary restriction should be taken everywhere. So mechanism of action is thiazides, as we know, it stimulates calcium resorption distal nephron while promoting sodium excretion. Side effects are muscle cramps, hyperuricemia, intracellular acidosis, and hypocytruria, which in turn again lead to stone formation, hypocytruria, and hyperuricemia. So it has to be monitored quite regularly. Sodium, these are things which are not used nowadays much. Sodium cellulose phosphate effectively decreases absorption of calcium but abundant due to GI intolerance and side effects. So these are not used now, but earlier historical importance is there, so we should know. Thiazides, limited long-term effectiveness is there in AS type 1. Other hypocalciuric agents are hydrochlorothiazides, indapamide, amyloid thiazide. This amiloride thiazide is important, is very important because amiloride is a potassium sparing diuretic, while thiazide causes causes excretion of potassium. So if we add both of them, potassium citrate is not needed additional to be given while this. Trientrin is also can be given, but it can cause primary trientrin stones. Orthophosphate it can inhibit 125 dihydroxyvitamin D synthesis, reduces urinary calcium by binding calcium in intestinal tract, has a role when other methods are ineffective. When other methods are proved ineffective, you can try this. We have never tried and got to a stage that we have to use orthophosphate for any case. AH type 2, no specific drug treatment is needed. Moderate calcium intake 400 to 600 milligram per day and high fluid intake sufficient to achieve a minimum urine output of 2 liter per day is enough. Avoidance of excessive sodium intake further decreases hypercalcemia type 2. Dietary bran is a rice bran, binds intestinal calcium and increases urinary pyrophosphate. Thiazide plus bran is superior to bran alone. Renal hypercalciuria. It is due to wasting of, as I have told repeatedly, it is due to wasting of calcium by functioning nephron. There is leak from the nephrons. Hypercalciuria during all phases of fasting, loading, or restriction of dietary calcium gives clinches the diagnosis of renal hypercalciuria. Treatment is thiazides and potassium citrate as before. Sustained correction for up to 10 years can be achieved by this method. Resorptive hypercalcemia is mainly produced by primary hyperparathyroidism from a dominant adenoma in the parathyroid or diffuse hyperplasia of the parathyroid. We have hypercalcemia with hypercalciuria in all phases, and there will be raised intact PTH in that. Treatment has to be undergone. You have to consult a surgical endocrinologist to get your parathyroid all the four out. And there is no established medical treatment for this. Orthophosphates are used only when surgery cannot be undertaken. Here, orthophosphates have a role for in the case of parathyroid and resorptive hypercalciuria. Other variety, now we will come to heterogeneous nucleation varieties. Two varieties are there. One is hyperuricosuric calcium oxide nephrolysis, where oxalate and hyperuricosuric are combined together. When the oxalate absorption excretion more than uric acid excretion more than 800 milligram per day, there is heterogeneous nucleation, and so hyperuricosuric along with pH more than 5.5 predisposes to HUCN. So both these conditions should be there. Where it is found when there is increased dietary purine intake, like in gout, myeloproliferative diseases, lymphoproliferative diseases, polycythemias, thalassemias, pernicious anemias, we can get this kind of stones. Treatment is to decrease dietary protein intake. Allopurinol decreases uric acid production by inhibiting XAO, xanthine oxidase. Potassium citrate alters the urinary milieu in hyperuricemia and decreases supersaturation of uric acid. So it can also be used, but allopurinol is the primary drug. Hyperoxaluria is more than 40 milligram per day. Enteric hyperoxaluria happens when there is a fat malabsorption, which results in saponification of fatty acids with divalent cations such as calcium and magnesium, thereby reducing calcium oxalate complexation and increasing the pool of available oxalate for reabsorption. It happens in diarrheal syndromes, small bowel resection, and genoileal bypasses. You have to go for oxalate restricted diet with high fluid intake and antidiarrheal agents. Probiotics can be taken, and potassium citrate can be used to take. Cholestyramine and can be also be used. We can have to replace the dietary fat with medium chain triglycerides to correct malabsorption. That is to be done. Now, primary hyperoxaluria is a genetic, rare genetic autosomal recessive condition of glyoxylate metabolism. Glyoxylate is of basically three types. PS type 1 by AGT transferase enzyme, alanine to private is there. In type 2, there is a reductase enzyme deficiency is there. And in type 3, there is aldolase deficiency is there. All these three. Type 2 requires kidney and liver transplant both, and type 1 can be. It presented in childhood with early death before NG and early diagnosis, and combined liver transplant has to be done, liver kidney. Dietary hyperoxaluria, oxalate-rich foods Increased animal, how it is caused? Oxalate rich foods are there, increased animal protein is there, severe calcium restriction is there, ascorbic acid supplementation, there are reduced levels of oxalate formages, and cystic fibrosis patients. These patients come with your this dietary hyperoxaluria. Other causes hypocyturic calcium oxalate nephropathy. That heterogeneous enucleation, which I told, two or three instances are there. This is one of them. Here we have when citrate is low in females less than 550 milligram per day, and in male less than 450 milligram per day, we have this phenomena. Distal artery type 1 is the most common one. In hypokalemic, hypochromia, non-anion gap metabolic acidosis is there. It causes abnormal collecting duct function, and calcium phosphorus stones are common in this. Two-thirds of patients are adults. Nephrolithiasis and nephrocalcinosis is there. Infants present with vomiting or diarrhea and failure to thrive, while children present with renal stones and metabolic bone disease. Distal tubular acidosis is found in all these conditions listed: obstructive uropathy, recurrent pyelonephritis, ATN, renal transplantation, analgesic nephropathy, sarcoidosis, idiopathic hypercalciuria, and primary hyperparathyroidism. So treatment has to be given. Potassium citrate has to be given to correct the metabolic acidosis and hypokalemia, and large doses may be required in severe acidotic cases, but the target dose in children should be 3 to 4 MEq per kg per day in divided doses. Chronic diarrheal states, findings like enteric hyperoxaluria, moderate decreases in urinary citrate excretion with associated low urine volume should be there, and treatment should be potassium citrate in 60 to 120 MEq in 3 to 4 doses, and liquid preparation is preferred due to rapid intestinal transit time. Hypomagnesuric calcium nephrolithiasis less than 80 milligrams. So low urinary magnesium is there, hypocyturia, and low urine volume is there. It is mainly found in patients undergoing chronic thiazide therapy, inflammatory bowel disease causing malabsorption, or laxative abuse. So magnesium is very important part in prevention of stone formation. So that has to be always taken care of. That there is no magnesuria that has to also be seen. Magnesium supplementation is beneficial in stone reduction, and use of magnesium is limited by the risk of diarrhea, like magnesium oxide and hydroxide. Potassium magnesium citrate may restore urinary magnesium and citrate levels with minimal GI side effects. So nowadays, all the drinks which we get, syrups which we get for stone prevention, they all have this potassium magnesium citrate only, along with vitamin B6 also is there, and along with other vitamins to prevent stone formation. Uric acid stone formation, it is the end product of urine metabolism, and it is formed in acidic pH, and pH higher than 6.9 greater than 90%, uric acid is ionized and soluble. The three main determinants are low pH, low U volume, and hyperuricemia. So dietary diathesis mainly predisposes to it. It is actually a stone forming propensity characterized by low urine pH of unknown etiology. Actually, major management is to increase urinary pH more than 5.5, preferably between 6 to 7.5. Alkalinization to a pH. If you do a pH more than 7, it should be it increases the risk of calcium phosphate. So that's why a range of 6 to 6.5 has been mentioned. Potassium citrate therapy has to be given. Allopurinol if hyperuricemia or hyperuricemia is present, then we can go. Cystinuria is a rare disease in Indian subcontinent. It is basically a disease of the whites, where their inability to reabsorb dibasic amino acids. Cola is the mnemonic of cysteine, ornithine, lysine, and arginine. It results in accumulation of cysteine, causing crystallization when concentrations rise above the saturation point, roughly 250 milligram per liter per urine. Young girls basically are affected. Aim is to reduce the urine concentration of cysteine to below its solubility limit of 200 to 300 milligram per liter. High fluid intake to produce 2.5 to 3 liter per day of urine has to be taken. Urinary alkylation by potassium citrate has to be done, and use of cysteine binding agents, which I will tell you later, has to be used. Mainly alpha mercaptopropanyl glycine, diapronine on thiola, which is the name, and dipenicillamine and captopril can be used for cysteine. Struvite stone formed in alkaline pH. It is basically an infectious stone. When urine with the urea is producing bacteria in an ammonium-rich environment is there, women produce more infection calculi than men because women are more susceptible to UTI than men also. Infection calculi most likely produce staghorn stones and symptoms of UTI may be present, may not be present. Struvite stones, there is no such as medical management. You have to go for surgical therapy first hand. PCNL first line therapy managing complex renal staghorn calculi. For small stones, you can go for RIRS also. Complete elimination of all infection stone material essential for prevention of recurrent stone formation. Antibiotic prophylaxis can be taken. Hemlacridi irrigation is for practice some places where the residual fragment is left after the removal of the larger fragment. Small fragments are there. You can go for this dissolution of this fragments. Acetohydroxide is also a urease inhibitor which reduces urinary saturation of struvite and it retards stone formation. It also prevents recurrence of and this can also be used for prevention, but it is mainly avoided at all costs because of high rate of thromboembolic phenomena. So this is a final chart which we discussed till now. If previous all the things are there, if previous episode is there, no, then you just take urine output to 2 liter per day. More than that, sodium intake should be decreased. Meat intake should decrease in all types. If there is a previous episodes, look out whether all these conditions are there or not. If they are there, go for serum studies, 24-hour serum to urine studies. Uncomplicated calcium stone disease, where there's normal calciumia, no bowel disease, and no UTI. Look for calcium urine level. If there is normal calciuria, give them potassium citrate. If patient is having hypercalciuria, give them thiazides. With potassium citrate, if urine citrate value is normal, with potassium citrate, if there is a decreased urine citrate. So this has to be done. If other stone diseases are there other than calcium, then hypercalcemia, hyperparathyroid investigation you do. For uric acid stones, give potassium citrate. Relapse is there, go for allopurinol. In hyperuricemia, gout, go for allopurinol. In cystinuria, go for thiola, alpha-marcaptoglycerin. Infection studies, go for antibiotics. Acetohydroxide for severe cases, but it doesn't comes to down to use at that level that you have to do acetohydroxylic acid. These are the drug doses which can be used. Normally, the syrups which we prescribe normally have all these most of them things in that. Vitamin B6 is given in that, potassium citrate is given that, magnesium is given in that. So we try to prevent the future episodes by giving all these things to make the urine less susceptible to stone formation. These are at last I will just like to tell you about the medications which can lead to calculus formation. Calculi formed from drug now Evindenavir, it's the antiretroviral drug. HIV nowadays it is not much used, and nowadays most of the stones are formed by ritonavir or atazanavir. Actually, form is ephedrine is also a drug not used nowadays. Triamterene is being used, so it forms the primary stones. Magnesium trisilicate antacid, this is are very commonly used and they give a high propensity of stone formation. Cotrimoxazole or trimethoprim, sulfamethoxazole also can form primary drugs. So that has to be taken in mind. The calculi provoked by drug, all these are by carbonic anhydrase inhibitor in any form or other, like carbonic topiramate, also by through carbonic anhydrase inhibitor. It also inhibits carbonic anhydrase, though it is a separate drug, but it inhibits also carbonic anhydrase. Furosemide by hypocytruria or vitamin C in excess, vitamin D in excess, and laxatives. These are all formed in calculus. So in history for taking this drug should be taken in metabolic evaluation. Thank you. आते आती